I'm going to talk about early mortality in newly diagnosed atrial fibrillation. And here are my disclosures. Garfield AF recruits patients with recent onset atrial fibrillation diagnosed within 6 weeks prior to entry into the study. The average patient in Garfield is recruited 2 weeks after diagnosis of AF. And this early recruitment time stands in contrast to the recruitment in 3 other registries, Gloria, Orbit, and Prefer, which have a much longer time window for recruitment of patients into the registries. We can go back to the Framingham study where a curious observation was made that men and women with atrial fibrillation have an early, sudden spike in their mortality after the diagnosis of atrial fibrillation is made, compared with men and women in the Framingham study who do not have atrial fibrillation. What we find in Garfield is that in the first month after entry into Garfield, there is a 60% increase in all-cause mortality compared with the average mortality throughout the 24 months of follow-up. And in months 2 to 4, we see about a 20% increase in all-cause mortality compared with the 24-month period averaged out. Here you see the 95% confidence intervals for all-cause mortality at 1 month and from 2 to 4 months. And in this table, we also see that the rates of mortality through the various monthly intervals are more or less stable for the first year and for the second year of follow-up. So something very curious is happening early on with respect to the increased rate of death. Not only is mortality increased by 29% during the first 4 months of entry into Garfield, but we see similarly the stroke rate is 35% higher during the first 4 months of follow-up in Garfield compared with the first 24 months of follow-up, and the major bleeding rate is up by 56% in these first 4 months of Garfield compared with the average follow-up over 2 years. Now, keep in mind the 6-week time window for entry into Garfield after AF is diagnosed. Within this 6-week period, if this observation really holds true, we would think that the early birds, those who are recruited within the first week or 2 of the 6 weeks, would have higher event rates than those admitted into Garfield toward the end of the 6 weeks. And sure enough, when we look at those recruited in the early part of the time window into Garfield, their standardized mortality rate is higher than those recruited in the latter part of the 6 weeks, and also the standardized incidence rate for major bleeding is increased very early on. This leads to 2 important research questions. We examine the baseline characteristics to ask, is the higher mortality rate during the first 4 months driven by subgroups of patients? And when we examine the causes of death, is the higher mortality rate due to cardiovascular deaths, non-cardiovascular deaths, or other causes of death. Let's go back to the first month of entry into Garfield and look at the all-cause mortality rates by comorbidity. Those patients who had a previous myocardial infarction or unstable angina have a 13-fold greater chance of dying during that first month than they do during the average of the 24 months of follow-up. Those patients with moderate to severe chronic kidney disease have a 14-fold increase in likelihood of dying during that first month compared with the 24 months of follow-up. And similarly, those patients with prior stroke have a 14-fold increased likelihood of dying during that first month. When we look at the first 4 months of all-cause mortality in Garfield, we don't see such striking changes as we do in the first month, but the same pattern persists. Previous MI or unstable angina, 10-fold increase of mortality. Moderate to severe chronic kidney disease, 12-fold increase in mortality. And previous stroke, 9-fold increase in mortality over those first 4 months of follow-up. Now, the mortality rates are higher in the first month than overall during the 2-year follow-up in different subgroups. Let's go on and look at age. Somewhat counterintuitively, those admitted into the Garfield study who are less than 65 years of age had a more than 2-fold increase in mortality during that first month compared with the other patients in Garfield. And those with a CHA2DS2-VASc score of 3 or greater had a 70% increase in mortality during that first month compared to those with a lower CHA2DS2-VASc score. Here we look at the causes of death during 2 years of follow-up, and we divide our patients into the first month, months 2 to 4, and the remaining months 5 to 24. What we see for cardiovascular death, it certainly is the dominant cause of death. And in month 1, we see a very high rate of death. This goes down quite a bit by months 2 to 4 and plummets further by months 5 to 24. The same pattern is present in subgroups, including those with myocardial infarction, congestive heart failure, or sudden death. Note that those who died of non-cardiovascular causes of death do not have this early mortality rate. Here, we look in Garfield at the first 200 days of follow-up. We look first in all patients, and we see the blue represents all causes of death, and the green is cardiovascular causes of death. Cardiovascular causes of death dominate for all patients, for patients with previous MI, for patients with moderate to severe chronic kidney disease, and for patients with previous stroke. Well, let's compare the Garfield findings to those from the United States Medicare database, which is comprised primarily of patients aged 65 years and older. Again, in the U.S. Medicare database, we see an early steep rise in mortality, which is represented by this top line in the graph. But we find a variant here in that heart failure, both in the primary study cohort, in those with recent heart failure, in those with recent myocardial infarction, is the most common subgroup. So heart failure is very much linked to the mortality. And for recent stroke, stroke is the biggest contributor, but then heart failure. We conclude that mortality rates in Garfield were higher during the first month and during the first 4 months than the overall rate during 2 years of follow-up. And cardiovascular death seems to be the most important component of the early mortality. Mortality in the first month was higher in patients with prior MI, moderate to severe chronic kidney disease, and prior stroke than in patients without these comorbidities. Comorbidities may account for some of the excess mortality risk, which points us to the importance of an integrated care approach. And we see that an integrated care approach is needed for comorbid conditions with common risk factors and pathologies. In this scheme, atrial fibrillation is center, and we see all the various comorbid conditions, and our challenge is for integrated care. Thanks very much.